Last but not the least, to talk about catecholamines and COVID is no other than our very own past president of the PSEDM, Professor Leilani B. Mercado-Asis. With Master's Studies in Public Health at the UP Open University, she is now the Program Director at the UST Master in Public Health International. The immediate past president of the Philippine Society of Hypertension, she is quite indeed a visionary, having mastered in distance education, major in instructional design, even before distance learning became a necessary trend in these current times.
Good day to everyone. My topic for today is catecholamines and COVID-19. I have no conflict of interest related to the topic. The topics involve catecholamine physiology, pheochromocytoma and paragangliomas and their adrenoceptors, and the PPGLs and COVID-19. The sympathetic neurons and chromaffin cells share the same progenitor in the neural crests. In the presence of established transcription factors, they acquire catecholaminergic features and phenotypes. The final target, which are adrenal medulla, paraganglia, and sympathetic ganglia, have been demonstrated to be influenced by glucocorticoid and glucocorticoid receptor signaling factors. These factors are very important for the survival of the chromaffin cells. The mother substance for catecholamine synthesis is tyrosine. It starts with the rate-limiting conversion of tyrosine to dopa and dopamine. In the noradrenergic neurons, the dopamine are converted into norepinephrine. Leakage of norepinephrine in the cytosol in the presence of phenylethanolamine and methyltransferase, norepinephrine is converted into epinephrine. The catecholamine metabolism brings about the byproducts that are used now for measuring and diagnosing chromaffin cell tumors, and these are metanephrines and normetanephrines, both in the plasma and in the urines. While in dopamine, 3-methoxytyramine is being used, that is measured in the blood. The COMT or catechol or methyltransferase byproducts in the urines are also important in the monitoring of tumor activity. Pheochromocytoma and paraganglioma are PPGLs that secrete excess catecholamine production. Pheochromocytoma is a chromaffin tumor in the adrenal medulla, while paraganglioma are tumors along the parasympathetic and the sympathetic chains. The common manifestations in pheochromocytoma and paraganglioma are due to the main actions of catecholamines on the various receptors. The alpha-1, alpha-2 stimulation in the skin and mucosa brings about vasoconstriction and localized secretion of sweat glands, manifested as pallor and diaphoresis. The stimulation of alpha-1 and alpha-2 in the peripheral vasculature results into vasoconstriction and manifested as hypertension, whereas stimulation of beta-2 receptor brings about vasodilation and results into orthostatic hypotension. The alpha-1 and dopamine 1 receptor stimulation in the brain brings about vasoconstriction that ascribed to the manifestation of severe headache in these patients with these tumors. The beta-1, beta-2 receptor stimulation and dopamine 1 brings about increase in heart rate, contractility, and conduction velocity that is manifested by palpitations, tachycardia, and sometimes angina. The stimulation of alpha-1 and beta-2 receptors in the lungs brings about pulmonary arterial vasoconstriction, tracheal and bronchial muscle relaxation that is manifested by dyspnea of these patients. By these patients, the simulation of alpha 1, alpha 2, and beta 2 in the gastrointestinal system decreases the motility and secretion, constricts sphincters, increases glycogenolysis and gluconeogenesis that is manifested by abdominal pain, constipation, and hyperglycemia. The stimulation of beta 1 in the kidney increases renin secretion that contributes to the hypertension. The stimulation of beta 1 and beta 3 in the adipocytes brings about increased lipolysis and manifested as weight loss. Pheochromocytoma and paraganglioma or PPGLs and COVID-19 has a lot in common as far as their clinical features are concerned. There are various potential interactions between them, which is excess catecholamines produced by these tumors and the cytokine production that leads to inflammatory state in SARS-CoV-2 or COVID-19. So the PPGLs are chromatin tumors whose disease processes are well studied in situations with surmounting stress. Therefore, the potential biochemical and physiological influences of excess catecholamines in these patients can be well understood. Catecholamines are expected to have a role in patients with critical illness, patients on vasopressor infusions, and patients who sustain some acute and chronic physical stresses. Therefore, the challenges involved in the management of catecholamine excess states are directly relevant to the treatment of patients with severe COVID-19. So here are the areas where potential interactions between COVID-19 and PPGLs may happen: ventilation perfusion in the pulmonary system, cardiovascular system, glucose metabolism and endocrine system, renin, angiotensin, aldosterone system, cytokines and immune and hematologic system, and thrombus formation. Cytokine storm syndrome is a state of hyperinflammation resulting from uncontrolled immune system activation. This results into elevation of macrophages. These are macrophage-derived cytokines, specifically interleukin 6, 10, 2, TNF-alpha, and granulocyte colony stimulating factor. There is also increase in acute phase reactants such as ferritin, seen in severe disease and can lead to increased mortality in patients with COVID-19. Lymphopenia in COVID-19 is a prognostic indicator of disease severity. An elevation of cytokine concentrations leads to hypercoagulability state that will make the patient at risk for thrombosis. So the cytokines and immune and hematologic system and thrombosis formation, there is involvement of beta 2 and alpha 1, alpha 2 adrenoceptors. The deleterious effect can be hypercoagulability, decrease in the natural killer cells, platelet aggregation, and greater susceptibility to SARS-CoV-2 infection. However, on the other side, there is beneficial effect because with beta 2 stimulation, there is activation of fibrinolysis and antithrombotic factors through adrenaline acute catecholamine elevation. There's also an increase in the natural killer cells and improved host viral defense. The alpha 2 stimulation can lead to bronchodilation and improved ventilation. The ventilation perfusion and the pulmonary system in the ventilation perfusion and the pulmonary system, it has been shown that in patients with COPD and asthma with COVID-19, there is high mortality and morbidity. The ventilation defect comes about through diffuse alveolar damage and granulocytic infiltration of bronchi and alveoli. The adrenoceptors involved are alpha 1 and beta 2. With alpha 1 and beta 2 stimulation, there is vasoconstriction in the ventilated alveoli that will lead to intrapulmonary shunt and hypoxia. However, on the other hand, the beneficial effect is decreased in the bronchial gland secretion and improved ventilation. Hyperglycemia is associated with dysregulated immunity. Both type 1 and type 2 diabetes are risk factors for severe COVID-19. Diabetes is significantly independently associated with COVID-19 related mortality due to ARDS, septic shock, acute kidney disease, and thrombosis. COVID-19 in Hubei province in China showed that patients who had type 2 diabetes had significantly higher mortality than patients without diabetes. The primary adrenoceptor involved is alpha 2. Its deleterious effect is that there is beta cell dysfunction that leads to hyperglycemia. However, the beneficial effect can be that the catecholamine-induced hyperglycemia could counteract hypoglycemia in patients with severe COVID-19 infection. Hypertension in these patients with COVID-19, they are found to be 2 to 3 times experiencing increased mortality. They are likely to be ICU'd and intubated. The mechanism is a viral entry through angiotensin converting enzyme 2. The conversion ACE2 is the one that converts angiotensin 2 to A1 to 7. The A1 to 7 are molecules for vasodilatory and anti-inflammatory functions. ACE2 in these situations are degraded so that there will be excess angiotensin 2 vasoconstrictive effects, thereby leading to cardiovascular untoward events. 71% of COVID-19 patients die from fatal cardiovascular complications like MI, arrhythmia, and stroke. In acute catecholamine surges, there is increase in the risk of lethal complications in the setting of COVID-19, such as heart failure, cardiomyopathy or Takotsubo syndrome, hypertensive emergencies, vasospastic MI, and myocarditis. So in this system, the ones involved are the alpha 1, beta 1, and beta 2 adrenoceptors that leads to vasoconstriction and hypertension crisis. Adrenaline or noradrenaline with alpha 1 blockade can precipitate hypotensive shock or distributive shock in patients with COVID-19. However, on the other hand, the beneficial effect of catecholamines with this involvement of these receptors is that catecholamine-induced vasoconstriction might compensate for the COVID-19 distributive or cardiogenic shock. Overall, there is a question, is it the cardiovascular morbidity in pheochromocytoma related to blood pressure or to the catecholamines? Stock and his group studied 109 pheochromocytomas and correlated their PO diagnosis with a group of patients with essential hypertension. They found out that even if the patients with essential hypertension have higher mean blood pressure versus those of pheochromocytoma patients, the cardiovascular event was significantly higher in patients with chromophene tumors. Why? Recently, it has been observed that there is evolving presentations of patients with chromophene tumors, their laboratory and imaging features, and the outcome. The age groups are usually young, presenting with the usual pheochromocytoma paraganglioma symptomatology. However, the symptoms um, are specifically observed with those presenting with acute coronary syndrome, congestive heart failure, and severe arrhythmia. But when they are tested, the troponin was normal with an elevated creatinine kinase. What is dramatic in their imaging feature is their 2D echocardiographic results showing severe dyskinesia in some with diffuse myocardial edema. The clinical outcome can be benign with resolution after adrenalectomy, or worse, they will succumb to death. This is a very interesting report on 3 cases of pheochromocytoma with COVID-19. Case 1 to 3, the case 1 was seen as a telehealth consult and the other 2 were on a face-to-face setting. All were elderly. Case 2 had the florid pheochromocytoma symptomatology. All of them are on treatment, 2 with um, calcium blocker, 1 with RAS blocker, 2 with RAS blocker, and the other one with alpha blocker. The RT-PCR for COVID-19 was done in this patient as hospital protocol for admission. All were asymptomatic for COVID-19. However, all had a positive COVID-19 result. The tumor were large. The tumors were large, but with benign features. Hormonally, the norepinephrine's and epinephrine measurements showed very high result both in the urine and plasma for the 3 patients. All were managed with adrenalectomy and removal of the pheochromocytoma. In the perioperative course, it was uneventful with resolution of the pheochromocytoma symptoms after surgery. The patients remained asymptomatic as far as the COVID-19 infection was concerned. So the insight here are, although there was marked increase in catecholamines due to pheochromocytoma, the clinical course of the patients with COVID-19 was uneventful. The absence of cytokine storm could have been a factor for the uneventful clinical course of the COVID-19 infection in a setting of increased catecholamines. Could it be that the deadly duo in COVID-19 are acute surge of catecholamines in an already cardiovascular in a patient with already cardiovascular abnormalities in an environment of hyperinflammatory state due to cytokine storm in COVID-19? So let's answer that later as we proceed with the lecture. Here again, our own patient, a 20-year-old with a very big chromophene tumor and presented with dyskinesia of cardiac dyskinesia of the symptom into the echocardiographic study. The group of Sanchez, Recalde et al. Showed the pheochromocytoma-related cardiomyopathy in a patient with pheochromocytoma. There was normal angiogram, a kinetic mid-ventricular segment, which normalized, including the ejection fraction, 14 days post-adrenalectomy. Here is a 25-year-old male, sadly, who succumbed to um, cardiovascular untoward events. He presented with a full-blown acute cardiovascular um, manifestation of chest pain, tachycardia, dyspnea, and respiratory and heart failure. He was intubated in ICU with an increased troponin, with an elevated troponin I. To the echocardiogram, ejection fraction was very low, very abnormal echocardio, 12 lead EKG, very high catecholamine levels, and he eventually deteriorated, and histopathologic findings showed that indeed he has pheochromocytoma. De Miguel and her colleagues showed that in patients with catecholamine, excess catecholamine, they present with catecholamine-induced myocarditis, as shown in this MRI of the patient pre-adrenalectomy, and the myocardial edema or myositis improved post-adrenalectomy. So, Takotsubo syndrome is actually a reversible cardiac condition characterized by acute left ventricular dysfunction, usually in the setting of physical or emotional stress. This has been described a long time ago, where they found inflammation of the myocytes. However, there is a high burden of if there is a high burden of myocardial injury, the mortality will be very high, from 19.7 to 27.8%. Here is a report of an 83-year-old female with fatal Takotsubo syndrome in critical COVID-19 related pneumonia. The 12-lead echocardiogram showed diffuse ST segment and Q waves in the peripheral inferior leads and precordial leads. There is left ventricular ballooning, and the angiography of the coronary arteries were normal. The patient died, and the gross picture of the heart at autopsy showed hemorrhagic area on the epicardial surface with extension. In COVID-19, we know that there's a fulminant cytokine storm demonstrated by elevation of inflammatory cytokines. In COVID-19, patients had lower left ventricular ejection fraction, higher left ventricular volume, and high sensitive troponin T, and higher MRI markers of inflammation. Cytokine release syndrome is often accompanied by catecholamine surge, which can predispose to Takotsubo syndrome in COVID-19 patients. Sharma and his colleagues looked at patients with Takotsubo syndrome, either reported individually or in a series. Here is the summary of those individuals in a case series as far as their clinical features are concerned. The prominent presentation is dyspnea, and on imaging, there is wall motion abnormalities in 100% of the patient evaluated. The in-hospital complication is acute respiratory distress syndrome and kidney insufficiency, and the outcome can be good with resolution of the problem, but bad 40% will succumb to death. In this report, majority of patients were treated with anticoagulation. The oral anticoagulation therapy was considered as very important in patients high risk for Takotsubo syndrome, especially in older age group and those with reduced left ventricular ejection fraction. 58% were treated with hydrochlorothiazide, hydrochloroquine, 29.4 with antivirals, vasopressors, and beta blockers. 5 patients were treated with an interleukin 6 inhibitor, tocilizumab, and interestingly, all these patients had improvement either clinically or in laboratory findings. This will be discussed further at the end of this lecture. The outcome showed that 54.5% developed cardiac complications like AF, acute failure, supraventricular tachycardia, and biventricular heart failure. 73% were discharged, but 3 were hospitalized due to ARDS. But what is interesting is that there was a markedly there was a big difference between the mortality of patients with COVID-19 and Takotsubo syndrome, 14.8% versus 5.8% of those COVID-19 without Takotsubo syndrome. So the conclusion showed that there was no major gender differences in the occurrence of TTS in COVID-19. However, age is an independent risk factor. So it has been shown that TTS in COVID-19 have higher mortality rate from cardiogenic shock. So early diagnosis is important and they should be screened for this syndrome so that optimal treatment may be instituted right away with antiplatelet medication or beta blockers if indicated. How about catecholamine treatment of COVID-19 as was shown in the previous slide? Is epinephrine used in COVID-19 a friend or a foe? Epinephrine has multifaceted utilization in our clinical practice. We use it through its alpha 1 receptor stimulation as its vasoconstriction, especially those with cardiogenic shock and hypotension. Likewise, the beta 1 adrenergic receptor stimulation is needed for this situation with cardiogenic shock. On the other hand, we use it for anaphylaxis for the decrease in the tracheal and bronchial edema and its bronchodilation effect through the beta 2 adrenergic receptors. However, there is a narrow therapeutic window of epinephrine when you look on this figure to its deleterious effect. So the common pharmacological effects that occur at our recommended doses are simple agitation, anxiety, headache, and palpitation. If with overdosage, it may lead to MI, congestive heart failure, arrhythmia, and stroke. RAS blockers may increase adverse events with these compounds. Vulnerable populations are the elderly or extreme of ages and those with hyperthyroidism and existing cardiovascular disease. So these are the populations you have to be very careful about when you use epinephrine in COVID-19. Some groups do not look at the dosage. They look at the pulses and the oscillations of epinephrine when they consider to use it in patients with COVID-19. So less than 3% of patients who are young were hospitalized with no ICU admissions or fatalities, and that has been observed globally. But there are increased percentage of patients who are old, who are admitted to hospitals, resulting to ICU admissions and case fatalities. Here, they observe that the circadian amplitude of the epinephrine rhythm is higher in children than in the elderly. So, and they reported that nebulized beta 2 agonist medicines were responsible for the decreased severity of COVID 19 in patients with asthma on maintenance medications with beta 2 agonists. Overall, asthma is considered a high medical risk factor for COVID 19, but not associated with severity and a need for hospitalization. So, another kinetics of epinephrine is that the background is natural killer cell activation depends on CD8 and tumor cell involvement and T cell involvement. In H7N9 disease, patients who rapidly recovered were found to have early CD8 and T cell responses. For mounting an antiviral immune response, a certain degree of adrenergic signaling by catecholamines is required. Recently, they've shown that CD8 and T cells positively correlated with epinephrine oscillations and their population increased after low dose epinephrine infusion. How about the alpha 1 adrenergic receptor antagonist versus cytokine storm? The premise is that subset of patients with COVID-19 develop cytokine storm with eventual ARDS. Alpha 1 mediated vasoconstriction of well aerated alveoli leads to intrapulmonary shunting and hypoxia. So we have to block that receptor action. A report has shown that prophylactic inhibition of catecholamine synthesis with metyrosine, a tyrosine hydroxylase antagonist, reduced levels of catecholamines and cytokine responses with markedly increased survival following various inflammatory stimuli in mice. The alpha 1 antagonist prazosin prevented cytokine storm, requirement of mechanical ventilation, and reduced mortality in patients when on this medication prior to hospitalization for COVID 19. Likewise, beta 2 can mediate vasoconstriction of already poorly ventilated alveoli that leads again to intrapulmonary shunting and hypoxemia. A blockade of this receptor with the presence of beta 2 receptor stimulation can precipitate hypotensive shock or distributive shock in patients with COVID 19. The use of propranolol can inhibit neovascularization in vivo and reduces vascular endothelial growth factor expression in mouse retinal pigment epithelium and choroidal endothelial cells in culture. Propranolol, which is a non-selective beta-adrenergic blocker, has found to reduce inflammatory cytokines including interleukin 6 and TNF alpha and some inflammatory transcription factors. Importantly, it decreases platelet aggregation. So Barbieri pointed out that the possible benefit of beta adrenergic blocker in patients with SARS-CoV-2 depends on which phase of the disease of COVID-19 disease the patient is in. If you got the patient on phase 1, which is the viral entry. You, use of beta 2 antagonists blocks the viral replication. In phase 2, it can decrease macrophage recruitment in lung tissue and infiltration so that inflammation will be decreased. But if you got and use it in phase 3, you can decrease interleukin 6 levels and other compounds that will lead to cytokine storm. Interleukin 6 is can mediate signaling in adrenal medullary chromatin cells. It can influence and alter gene expression necessary for catecholamine actions and its adrenal medullary response to stresses. In the rat cardiac fibroblasts, interleukin 6 increases highest with the stimulation using norepinephrine in this study. Ulhak and his group used interleukin 6 as a potential biomarker of COVID-19 progression. Here, in these 19 studies, although there is increase in heterogeneity, they were able to show that interleukin 6 indeed is highest in patients, statistically significant at that, who have severe COVID-19. So as a potential biomarker for severity of COVID-19, circulating interleukin 6 levels are closely linked to the severity of COVID-19 infection. An increase in interleukin 6 levels implies a possible shared mechanism of cytokine-mediated lung damage caused by COVID-19 infection. So the highly pathogenic SARS-CoV-2 is associated with rapid virus replication and a tendency to infect the lower respiratory tract, resulting in an elevated response of interleukin 6 induced severe respiratory disease. So it is reasonable that immediate initial evaluation of interleukin 6 level be performed upon hospital admission of COVID-19 patients. So because of these several studies that had happened the past 2 years, they developed a compound which is tocilizumab. It is a recombinant humanized anti-interleukin 6 receptor monoclonal antibody. Another compound is sarilumab. Both of these are approved for rheumatoid arthritis but not for COVID-19. They hypothesize that modulating the levels of pro-inflammatory interleukin 6 or its effects may improve the course of COVID-19. The initial studies showed tocilizumab treatment lowered the incidence of duration of intensive care unit and hospital stays in patients with COVID-19. Compared to placebo in this REMAP-CAP trial, the use of either tocilizumab and sarilumab reduced both mortality and time to ICU discharge and increased the number of organ support free days in patients with COVID-19. Other studies showed similar effect. One is the COVACTA, which showed lowered composite rate of mechanical ventilation or death, and the BACC. However, the BACC and other two studies showed no effect at all. So even if the results are divided, some members of the panel in the guidelines of using tocilizumab would administer a single dose of this drug, 8 milligrams per kilogram, in addition to dexamethasone. So the summary and insight of this lecture are: acute catecholamine surge can influence the course of severe COVID-19. Increased in catecholamine secretion is associated with increase in pro-inflammatory cytokines. Increased catecholamine levels can augment production of concentrations of pro-inflammatory cytokines. Cytokine storm leads to cardiovascular collapse, multi-organ dysfunction, and death in COVID-19. There is increased mortality in severe COVID-19 patients with Takotsubo syndrome and catecholamine adrenoceptor blockade showed reduction in mortality and morbidity. So, are catecholamines friend or foe? I think timing is critical, and looking at what phase of COVID-19 disease the patient is in is vital in using either alpha or beta receptor antagonists in manipulating the course of severe COVID-19 for patient survival. Indeed, the deadly duo are acute surge of catecholamines in COVID-19 patient with already cardiovascular abnormalities in an environment of hyperinflammatory state due to cytokine storm. The early recognition of this duo and managed optimally and very timely could be critical in reducing mortality in patients with severe COVID-19. This is my last slide. Thank you very much for listening.
Thank you, Dr. Asis. The Philippine Society of Endocrinology, Diabetes and Metabolism would like to award the Certificate of Appreciation to Dr. Leilani B. Mercado Asis in grateful appreciation for graciously sharing valuable time and endeavor as speaker during this 2021 PSCBM Virtual Annual Convention.